Hello and welcome to this webinar brought to you in partnership between London Vet Show, Closer Still Media, and PetsApp. It's our second one in this particular series. I'm Tom. I'm the CEO and co-founder of PetsApp. I'm also a vet, and I'm delighted to be your chair this evening. I'm joined by Dr Sue Paterson, who has been a dual Royal College of Veterinary Surgeons and European College of Veterinary Dermatology specialist in veterinary dermatology for more than 20 years. She is a fellow of the Royal College of Veterinary Surgeons, awarded for her contributions to clinical practice in the field of veterinary dermatology. Sue was, until 2 years ago, a veterinary director of a large veterinary hospital group in the Northwest. Since selling the practice, she has established a telemedicine advisory service and is passionate about making specialist veterinary advice accessible to both veterinary surgeons and the public. She has written 7 veterinary dermatology textbooks. I've read all of them, Sue, promise, including 3 on ear disease, a subject on which she is considered to be a world authority. She has written more than 90 refereed publications in English, European, and American journals, and lectured all over the world in more than 30 countries. She is an elected member of RCVS Council, where she is Education Chair and Council Lead for Sustainability. She is a past president of the British Small Animal Veterinary Association and the European Society of Veterinary Dermatology, and currently sits on the board of the World Association of Veterinary Dermatology. She is a trustee of Battersea Dogs Home and a supporter of Street Vets. Wow, Sue, we're very, very, very lucky to have you joining us from Cumbria. I'm told you have 2 children, and in your spare time, what spare time, based on that resume, enjoys nothing more than long walks across the Fells with her 2 Labradors, Saffron and Thornton, and her husband. So, yeah, just feel incredibly privileged and grateful to you agreeing to come and talk to us tonight, Sue. Over to you.
Thank you, Tom. After an introduction like that, no pressure, and I will be testing you on the textbooks a little bit
Thank you.
later on. So get your swatting hat on if you
get reading.
So thank you so much for inviting me to come along tonight. I thought that we choose this as a subject, the Friday night dermatological emergency. I have to say it's not something I've lectured on before, so I thought it would be a little bit of a challenge for me to put my thinking hat on and just look at this and decide how, as a specialist, I could perhaps guide primary care practitioners to triage cases effectively, because we know that at the coalface, life is hard. COVID's made life hard. Workforce shortages have made life hard. So it's really to hopefully guide people as to how we can provide helpful advice to members of the public to manage their animals and not compromise animal health and welfare. So thank you so much to PetsApp for inviting me. Those of you who don't know about it, I'm sure Tom will be telling us all about it later on. I'm sure he never misses an opportunity to do that, but thank you for allowing me to come. And what I'm going to talk about tonight is I'm going to divide the presentation into 2 pieces. I'm going to talk about what constitutes a perceived emergency. So these are the cases where we've all had them. I'm an ex-PDSA vet many years ago. We get conversations with clients where they phone us and they think that their dog's dying from their skin disease and they need to be seen as an urgent case. But many of these cases are actually, of course, not true emergencies. And what I want to do is to go through how to recognize those and little tips and tricks that we can actually provide our owners with to try and keep them comfortable until we can see them. And that may be because they phone us up on a Wednesday night and obviously we don't feel we need to see them over the weekend, or it may be just because you're up to your eyeballs in everything else and we need to create a little bit of time, a little bit of space in order to be able to see them perhaps later on in the week. And we're going to compare and contrast that with what I would consider to be true emergencies. And these are the ones where we can't really give advice over the phone to any great degree. These are cases that we really, truly do need to make space in our diaries for so we can actually see them. So here are our learning objectives for tonight. We're going to learn about the diseases that owners consider to be urgent, but do not need to be seen immediately, that we can manage virtually. Particularly, we're going to talk about pruritic skin disease, because pruritic skin disease is something that's very, very visual, very obvious to clients. There's nothing more frustrating as an owner of a pruritic dog. It's constantly scratching. They can hear it scratching when they're in bed at night, when they're watching the television, and it's something that stimulates people to pick up the phone and to give you a ring. What we are going to learn about, though, is what these true dermatological emergencies are. And what I would say is these are very rare. So the ones I'm going to talk about to start off with, the perceived emergencies, are common. The real emergencies are hugely rare, but I want to give you some pointers as to the sort of criteria I would consider are important when we're going to assess these and we're going to manage these virtually. And so what I want to use as a starting point is to just go back, heaven forbid, 12 months to when we all went back down into lockdown, and people like the BSAVA at the time produced these triage tools for cats and dogs. And it was almost a new concept for us as veterinary surgeons, having to triage cases to decide what we needed to see and what we didn't need to see. And although at the time it was pretty dreadful for everybody, I do think that we learned some lessons from lockdown, and I do think it has potentially given us the opportunity and the tools to work in a very different way to the way we did before. And I think many of us have learned how to triage effectively, and rather than just using the phone call, so the phone conversation that you have with the client, many of us have started to use visual clues. So we're using things like FaceTime, we're using things like Zoom, we're using things like Microsoft Teams. So we have the ability not just to talk to a client, but for a client to actually show us what their dog looks like. And when we're looking at something like skin disease, it's a very visual disease process altogether. We can get a lot of information looking at the distribution of clinical signs and looking at the types of clinical signs that are actually there. So COVID, I think, has taught it how to use our remote consulting skills to get the very best out of it. Now, when we look at this triage chart, the BSAVA triage chart here, what you can see, those of you who've not seen it before, I'm sure many of you have, at the top we have this red area, which are the urgent cases that really need to be seen on an urgent basis. And if I'm honest, there aren't really any skin diseases that fit into that category. It's not like a fit. It's not like a collapsed dog. It's not like a dog that's in respiratory distress. Pretty much all of the skin cases that need to be seen on a relatively urgent basis fall into this second category. And if we look at this in more detail, we can particularly pick out these two areas. First of all, pruritus, but pruritus leading to significant skin trauma. So that's where we need to use our clinical judgment, our clinical acumen, use the history taking over the phone, the ability to assess what the animal looks like, to decide if that pruritus is something that we need to address or whether that's something that can wait for just a routine appointment. The other big group of diseases that you can see there is angioedema, and we're going to talk about that, and we're also going to talk about more generalized swelling because there is particularly one condition which causes acute swelling of the skin. And then we're going to talk about severe skin ulceration, and those really are the true dermatological emergencies. There's quite a small number of those, but we'll show you some pictures and we'll talk about those towards the end of our presentation. So let's start off here, and let's start off with the first of those groups, and let's talk about pruritus leading to severe skin trauma. And one of the tools that we use when we're assessing degrees of pruritus is what we call this PVAS score. And this is the pruritus visual analog score. And that gives us an indication when we're talking to a client as to how itchy their dog is going to be. And this is something I would use as part of a normal consultation. However, the problem that we have is that when an owner phones us for an emergency, by the very definition, they think their dog is extremely itchy. They think their dog needs to be seen. So if you use a PVAS scale on a dog for a dog where an owner's phoned you because they're worried, they are not in a million years ever going to give you a PVAS score of 2. I absolutely guarantee that they're going to tell you it's going to be 8, 9 or 10. So although it's a useful tool, it's not something I would particularly suggest is going to be useful when we're looking at assessment of these on a virtual basis. If we are looking at diseases that cause pruritus, I broadly speaking categorize them into these 5 particular groups. And if I superimpose on that an arrow, I would suggest to you that the further you go down my page, the closer you get to the bottom of my page, the more pruritic those diseases are. So what you can see at the top is pyoderma. It's moderately itchy. Allergy, I would suggest to you, is also moderately itchy. And I would not consider allergy, uncomplicated allergy by itself, to be an emergency. It's also very insidious in onset. So these are much more chronic dogs. So I don't think they need to be seen urgently. When I'm looking at pruritic skin disease, whenever I'm asked to see a case urgently, it's almost always got ectoparasitic disease, and that tends to be scabies, or it's got malassezia infection. Those are the 2 single most common pruritic skin diseases that come to a dermatologist as an emergency. And so I would suggest to you those are the ones that we need to be thinking about addressing, and those are the ones potentially where we need to give advice to our owners. I've also added to that acute moist dermatitis, or hot spots, or wet eczema, because again, these are things that occur acutely. The allergy's been there for weeks. The acute moist dermatitis wasn't there before Mrs. Smith went shopping, and when she came back it was, and it's that acute onset that actually stimulates them to pick up the phone and to talk to a vet. So let's talk first of all about pruritic skin disease and the phone calls that we get from owners where they've got one of these conditions, what we can do to recognize them, and what we can do to try and help settle these down. What advice can we give to owners so they can manage them at home without actually compromising their animals' welfare? So let's start off first of all by looking at acute moist dermatitis. As I've already said, this tends to be a disease with a very acute onset. When we're looking at these lesions, I'm sure we've all seen them. They tend to be very well circumscribed. And a true acute moist dermatitis is not actually an infection per se. It's a surface colonization of the skin. It's an overgrowth of bacteria that's found on the surface. So it's not truly an infective process. There are certain breeds that we see where it's predisposed. So we see it particularly in things like golden retrievers. We see it in rotties. We see it in St. Bernards. And usually it's an acute exacerbation of an allergy. What things should we consider as our differential diagnosis when we're faced with a picture, as you've got on the right-hand side here of this screen, or a video consult with a client who's got a dog that presents like this? Well, the major differentials for me would be localized demodicosis, although that is unlikely to present in an acute way. It could be an area of deep infection, so furunculosis, or it could be neoplastic. Now, of course, if we have the advantage of getting this dog into the clinic, then the first thing that we're going to do with this lesion is we're going to clip it. And the minute we clip this lesion, as you can see here, what you can see now with this lesion is it's very well circumscribed. There is no evidence of satellite lesions, as we'd expect to see if there was infection there. We can see it's very much a surface-based problem. We can pick the skin up. We can assess to see if the skin is thickened, if there's plaque formation there. But we can't do that with a virtual consultation. If when we clip it, it looks like this, well, this is very different. Superficially, it will have looked exactly the same as that first photograph. But once we clip an area like this is not an area of acute moist dermatitis. This has got lots of isolated lesions. We've got central lesions there with peripheral lesions around the outside. This is almost certainly an area of infection. So when we're looking at these cases and when we're talking to owners, what we need to be aware of is what we think it is, but also our other differential diagnoses, so that when we discuss with the clients ways in which they can manage this at home, the drugs that we're going to recommend, the treatment protocols that we're going to put in place to keep these dogs comfortable, to buy ourselves some time, need to be things that do not make our differential diagnosis any worse. So what sort of things might we say to an owner when they present us with this acute onset, acute moist dermatitis? What sort of things might we consider? Well, there's lots of things we can send them to get in the way of over-the-counter treatment. And what I'm going to do is show you lots of pictures of lots of drugs. They're not particularly recommendations for those particular drugs, so I don't have shares in calamine lotion from Tesco. It's just really to give you a feel that these are things that they can go and get. So if a client phones you at 8 o'clock at night, there will be a Tesco somewhere with 24 hours, that's open for 24 hours. They will be able to go and get these products very, very easily to buy over the counter. So the basics when we're looking at an acute moist dermatitis is we need to clean it because the surface colonization of the skin. We need to dry it. So rules of dermatology, if it's wet, dry it. If it's dry, wet it. So these are moist lesions, so we need to actually dry it. And then what's really good, if we can, is to give them something in the way of an antipruritic. So heavy scrub, you can buy over the counter. You can buy that over the counter at Boots. You can buy that over the counter at Tesco's. Any supermarket, you'll be able to get hold of this. And this can be used to cleanse it. It's 4% chlorhexidine, neat chlorhexidine onto a cotton pad, cleanse the area, wipe it off well. So we've cleansed it now with any superficial bacterial colonization. We can then dry it. We get some calamine lotion and dab it on it. It dries it, it soothes it, it takes the irritation away. We may want to add in some antihistamines. I've just given you 2 common garden antihistamines here. Again, no particular preference for these. So Piriton, I've given you here, and I've given you cetirizine. Again, I've given you this as a generic, just from Boots. It could be from anywhere though. And I've given you dose rates for both of those. The skeptics would say that antihistamines are not fantastic as far as antipruritic drugs are concerned, because histamine is not the major inflammatory mediator when we're looking at allergic reactions. The skeptics would say, and I am one of those, is that antihistamines work by making animals sleepy. And of course, Piriton is a sedating antihistamine. But to be honest with you, that's often what they do in children. Promethazine is given to children who have eczema to settle them at night. We take night nurse if we've got a cold. Again, that's got antihistamines in to make us sleepy. So making an animal sleepy, if they settle and they are not as disturbed by their pruritus, I think is a perfectly adequate response. So in those sort of situations, there's lots of things that we can do to help manage these cases until we can see them, or until we can perhaps get another virtual follow-up with the client. The other one we talked about was malassezia. Anybody who's had candida, who's had thrush, will know how incredibly pruritic malassezia can be. These tend to be a little bit more insidious in their onset than acute moist dermatitis, but nevertheless, they can be highly, highly pruritic. And what you will find with many animals who have malassezia infection is they can get a little bit obsessive. So they'll have an area where they've got yeast infection. Of course, we know that yeast loves these poorly ventilated, moist areas. So the minute that area is traumatized by the animal, it's licked, it's chewed, it's rubbed, it will tend to perpetuate the problem and make things worse. So classically, when we're looking at malassezia infections, it's seen in intertriginous spaces. So if you're looking at a dog and it's licking its feet to pieces, and you get the owner to show you the dog's foot, if it's affecting the top of the foot, it's probably allergy, and it will probably cope. But if it's affecting this intertriginous area, this interdigital space, the likelihood is it's probably going to be malassezia, and we can do quite a lot to help manage that case. So you'll see it in foot folds like this. You'll also see it on necks. This is a little West Highland White Terrier, but you'll also see it in things, for example, like Spaniels who've got these big, thick dewlaps, or big, heavy, overweight Labradors. You'll see it. The other thing, the area where you'll also see it as well, is ventral abdomen. And this is a dog that's got 2 very distinct clinical signs on its ventral abdomen. It's got the very generalized erythema that's there, and that's probably because this dog's got underlying allergy. But then what you can see along its ventral midline, in that very prominent skin fold, you've got an area of much more intense erythema. There's evidence of superficial erosion, and that's almost certainly going to be because this dog has got a malassezia infection superimposed on that erythematous skin, and it's that malassezia infection that stimulated the client to give you a ring. They're poorly responsive to anti-inflammatory therapy, and so often these dogs are on anti-inflammatory therapy anyway, and what has happened is the owner has increased the dose of the drug. Maybe it's on Apoquel and they've doubled the Apoquel dose. Maybe it's been on steroids and they've increased the steroid dosage, and that in itself is a real clue that you're dealing with something other than an allergic etiology. Differential diagnosis, well, we've said allergy. Could be bacterial infection. Bacterial infection would tend to be more generalized, I would suggest. And of course, we always have to have Demodex on our list of differential diagnoses. So what sort of things might we consider in this situation? Well, similar to the ones that we talked about before. And again, think about our differential diagnoses. Make sure that whatever we do, we never make it worse. So again, something in the way of an antiseptic, Anhibiscrub, used at 4%. 4% chlorhexidine has excellent antibacterial property against both staph and Pseudomonas, but it's also got good antimycotic activity against Malassezia. So again, applying it on a swab, a sponge of some description, rubbing it onto that area is going to help. There are also a lot of proprietary creams that clients can buy over the counter. And again, I've just shown one of them here. There will be lots of own brands as well. You can buy both clotrimazole and miconazole over the counter. So again, we can send them down to their local supermarket or their local chemist to help. There's a range of anti-itch medications we may want to consider as well. Something like E45, it's straightforward, it's simple, it's something they can go and buy. And I haven't shown you a picture here, but there's a range of oatmeal-based preparations that clients can buy, which are made for humans. So there's the Aveeno range of oatmeal preps that are there in the way of soaks, in the way of shampoos, in the way of creams that, again, they can apply. And again, you can send them to get antihistamines. And again, it may be they don't have any antipruritic effect. It may be because they're working through sedation. When we're looking at pruritic skin disease, though, this is the one that comes out head and shoulders above absolutely everything else, ectoparasitic disease. And whenever I'm talking to new grads about history taking and differentiating ectoparasitic disease from allergy, allergy is insidious. If you ask an owner when an allergy starts, they won't be able to tell you. It will be last summer during the school holidays. If you ask someone when their dog's skin problem started, if they've got an ectoparasite, they'll be able to tell you pretty much to the day. So a dog that's got scabies, one day they're great and the next day they are ripping themselves to pieces. And the owner will say it was after a visit to the park, after we went on holiday to Wales, after it went away to the kennels. They can almost always tell you. And this is where the distribution of clinical signs can give you a huge amount of information. So you've got an animal with severe pruritus, but the distribution of clinical signs now can give you that clue as to what's going on. If we're looking at a dog that's got fleas, if we're looking at a dog that's got Clilottiella, their pruritus is nowhere near as bad as the dog that's got scabies. The distribution of their signs is almost always going to be dorsal. If we're looking at a dog with scabies, though, the areas that tend to be affected are generally the extensor aspects of the joints and the ear pinny. And if we look at this Labrador here, classical Labrador, as an owner of Labradors, they either eat fox dung or they roll in it, or a combination of both. Foxes are the carriers of scabies almost always, and we see them in both urban and in rural environments. And classically, you see this crusting and this hair loss around the periphery of this dog's ear pinna. So in a fit dog, they'll often tolerate it. In an older dog or a dog with comorbidities, they will rip themselves to pieces. Differential diagnosis is going to be allergy, is going to be infection, and these are dogs that are very, very uncomfortable indeed. This is a picture of a dog with fleas. As we said before, it's purely seen on the dorsal areas. So what can we do if we see an animal and we're pretty sure that it's got scabies, it's ripping itself to pieces, the owner's really distressed? We need to try and do something to make this dog as comfortable as we possibly can until we can see it. It may be the owner can't get in. It may be the owner's not got a car. It may be the owner's housebound. It may be you just can't see it at that particular moment in time. What can we actually do to try and help? Well, If the owner is able to get into the clinic, even if you can't see them, if it's one of your own clients and you can prescribe them drugs because you've seen it recently, then give it an isoxazoline. I've given you the 4 there that are available. They're all pretty good. They're all excellent against Sarcoptes, and that would be my stock treatment in any dog with severe pruritus. I would give it an isoxazoline of your choice. If, however, they've not been seen recently, they can't get in, you don't feel comfortable in prescribing a prescription drug like that, the next best thing you can do is tell them to go and get some fipronil. We know they can get fipronil from their local supermarket. We know they can get fipronil from their local pet shop. It is nowhere near as good as a scabicide, as an isoxazoline, or for that matter, an avermectin, something like selamectin, for example, or moxidectin. But it's the next best thing. And certainly if it's got fleas, it will help. The disadvantage of something like fipronil, it doesn't have the speed of kill that an isoxazoline has, but it will very definitely kill fleas. It will take the edge off scabies. So again, we're looking at something as a stopgap. Looking at itch relief, again, we've got our oatmeal-based products, we've got our E45s, our moisturizers, and again, we've got our antihistamines that we may want to consider giving them. So there's things that we can do, there's things that we can help, there's things that we can give them advice about over our video consultation to try and make these animals more comfortable until they can get to us or until we can actually see them. Let's think about the second big group of diseases now. Let's think about angioedema and think about severe swelling. So what do we do to recognize these, and how should we approach each of these cases? Well, angioedema, we've got a case here. You can see this is almost always acute onset. These animals have variable degrees of pruritus, but they get this large edematous swelling. It can be very localized, as you can see this dog on the right hand side, or it can be really quite generalized. Differential diagnosis, it could be an abscess, it could be bruising, it could be neoplasia. So the classical sign to differentiate angioedema and urticaria generally is it pits on pressure. So the thing you get your owner to do is you just get them to gently press on that area of swelling, and if it pits and then comes back again, that is really going to be nothing else other than fluid edematous swelling within the skin. These can be difficult to call because there's a real variation in the clinical signs that these animals present with. The classical one, we've all seen it, is the dog that snaps at the wasp or snaps at the bee and gets stung in the inside of its mouth, and they're very embarrassed about it and they're a little bit uncomfortable, but it's never going to be life-threatening. There are cases though where they can be stung in their throats, and obviously they can get respiratory distress, and that then changes the emphasis completely. Once you're getting an animal that's got respiratory distress, then these are things that we don't want to give advice to over the phone. These are cases that we need to see. And similarly, if you've got localized swelling like this and it's around the eye, I have no idea what that eye looks like underneath there. I have no idea what came first. Was it ocular disease that the animal traumatized, or was it periocular disease that the animal traumatized and then traumatized its eye? So when I've got an eye involved, again, these are cases that I really feel I need to see, because I need to see if there's a whacking big corneal ulcer underneath that. And if I give general advice over the phone to the owner of this particular Shar-Pei, it may be we get a perforating ulcer if the case is left. So what do we do with home treatment versus clinic treatment? If it's mild, if it's localized, if it's non-life-threatening, again, we may consider to use some antihistamines. Whereas I like Piriton for allergy and for pruritus generally, because it may have some sedating effect, I would suggest cetirizine is better for edema, for urticarial, angioedematous type of reactions. And you can certainly use up to 1 milligram per kilogram really very safely. So that would certainly be my go-to in the short term. If you think this is the mild case, this is the Labrador, as I say, that snapped at a sleepy wasp and got stung inside its mouth. If we're more concerned about these, then they need to come in. If it's generalized, if there's a respiratory distress, if you're worried that there's involvement of the eye, then you need to come in. Obviously, if there's ulceration there, you need to assess whether you want to give these dogs steroids or not. But again, if it's got severe life-threatening angioedema, that may be a decision that you may want to consider. But obviously, life-threatening disease, we're looking at high doses of dexamethasone, and we're also looking potentially at adrenaline to manage that emergency. So angioedema, a case of swelling where there's a very variable clinical presentation. And this is one of these situations where your history and your ability to chat to the owner, your ability to look at the animal and assess them can help you make the decisions as to whether you feel comfortable in prescribing something over the phone or over a virtual platform, or whether you really do need to see these animals. The other one that I put in here with severe swelling is canine juvenile cellulitis. Any ones of you have seen this, and I'm sure most of you have. This is a really acute disease. We tend to see this almost exclusively in very young puppies. We do see quite a marked breed predisposition for this, so particularly golden retrievers, dackies and Gordon setters, but I've seen it in a wide range of breeds. In this case, we get acute swelling of the face, particularly the eyelids, the lips, the pinna and the muzzle. You get massive lymphadenopathy. Occasionally, I perhaps should say rarely, you'll see involvement of other areas. But sometimes this is called big head disease because it really does just affect the face and the head of these animals. These are very sick puppies. They're often depressed, they're pyrexic. Often they have secondary infection, and they progress from swelling to develop signs of pustules and papules really very quickly. So this is a little border terrier puppy here. You can see it looking hugely sorry for itself. This is a close-up of its eyes just to show the severity of the disease. Another one here, a Labrador, and this, as I say, this disease will literally come on within 24 hours. And then again, a close-up of the ear. Acute onset, exudative otitis externa in a young puppy. Think about canine juvenile cellulitis. What sort of things should we do for this? Is there stuff that we can think about and prescribe over the phone, or is this a case where we need to see them? Well, very short term, I may consider giving some general advice about these, but I would suggest you really do need to see these cases. If you're going to do anything over the phone, if you're going to do anything virtually, then some warm soaks, some Hibby scrub, dilute solution, soak some towels in it and lie those on the dog to make it feel more comfortable. You could consider some analgesics. If we look at the data sheet for something like Pardale is recommended in dogs over six weeks of age. So you could probably extrapolate from that and use paracetamol, 10 to 15 milligrams per kilogram, if you wanted to in the short term, providing that dog is fit and it's eating and drinking. If it's more debilitated than that, then I probably wouldn't give it paracetamol at all. Usually, though, these dogs need to come in. You need to check for infection, you need to check for Demodex, because those are our major differential diagnoses. And then you need to hit these dogs with significant levels of steroid. 2 milligrams per kilogram is what you're looking at, and you need to do that for probably a minimum of at least 10 days. If you don't, they get worse. If you don't, they will get really severe irreversible scarring on their faces, and because this almost always occurs in expensive pedigree dogs, it's something that you want to try and avoid. And then antibacterial soaks again with chlorhexidine shampoo. So let's look at our final section. We're starting to ramp things up a bit now. We're starting to look at the much more severe diseases, and these are diseases where we're starting to see some life-threatening conditions. And when we're looking at severe ulceration, these are the 5 diseases that I would consider to be emergencies when we're looking in dermatological terms. These are immune-mediated diseases, though. These are not autoimmune skin diseases. Autoimmune skin diseases, things like pemphigus, for example, are very insidious in their onset. You will not get an acute flare of pemphigus. Pemphigus is uncomfortable. It's not particularly painful. It's not particularly pruritic. So whilst pemphigus is something that needs to be addressed, I would not consider that to be an emergency. Whereas these diseases here are diseases with an acute onset, They're rapidly progressive, and potentially, certainly with the last 4 on that list, they could become life-threatening. So again, as we move down our list here, we start to see increasing severity and increasing concern with the disease that's present. So let's look at these two first. We'll deal with these two together: eosinophilic furunculosis and drug eruptions. So eosinophilic furunculosis first. If you've not seen this as a disease, you will see it at some stage, I'm absolutely sure. This is a really acute onset, ulcerative, swelling disease which we find on the noses of animals. Rarely will you see it on other sites. Usually these animals are quite unwell, they're pyrexic and they're depressed. It's almost always seen in young, curious, long-snouted dogs that are, your average Labrador or your Retriever or your Collie that's sniffing about when it's out for a walk, and it's thought it's a very severe form of arthropod hypersensitivity. So whether it's a hornet, or whether it's a wasp, or whether it's a bee, you get this really severe reaction occurring on the noses of these animals. It could be autoimmune, it could be mucocutaneous pyoderma, it could be dermatophytosis, but none of those literally occur over the course of a couple of hours, and these dogs deteriorate over a couple of hours. I've got another example here of another one, and again you can see very severe ulceration. Differential diagnosis, if we're talking about autoimmune skin disease, for those of you who looked at that and thought that looks very much like a case of lupus. When we're looking at eosinophilic furunculosis, and it's present on both of these, you can see the planum nasale is relatively spared. The planum nasale is involved in autoimmune skin disease. It's never involved in eosinophilic furunculosis. So what do we do to manage these? Well, again, I don't think these are cases that we should try and manage remotely. We may consider very short term some analgesics to try and make these animals comfortable. You can suggest some bathing, but to be honest with you, this is really painful, and it's very unlikely that a dog is going to allow you to put anything on that in the way of warm packs or soaks, for example. So these dogs, I'm afraid, are dogs that almost certainly need to come in. And as with all of these cases, rule out infection, rule out Demodex, and then we need to give them significant doses of prednisolone. Prognosis is excellent. These dogs will resolve really, really quickly if you give them aggressive therapy for 7 to 10 days, then taper to an alternate day regime for 10 days, and then you can take them off the drugs completely. But it's one of these that I do feel when you come across it, you need to see. Drug eruptions, again, acute onset. Drug eruptions can present in a whole range of different ways. It can be really quite mild, as you can see here, where you just get a little bit of erythema, a little bit of urticaria. I wouldn't particularly consider that to be something that's an emergency, but you can see much more severe signs. So you can start to see signs, for example, of vasculitis, as you've got here. This is a dog that had a severe and acute onset vasculitis as a result of clavomox. So a very severe reaction to it. Another one here again, very severe, acute onset reaction, vasculitis, classical vasculitis lesions, punched out lesions on the foot pad of this dog. And this was a dog who had a reaction to potentiated, non-steroidal anti-inflammatory drugs. So drug eruptions can be really severe. They can be quite mild, but they can be very florid indeed, and they can mimic almost any other disease. They can certainly look like vasculitis, as we've shown you, but drug reactions will also be underlying causes for some of the more severe diseases we're going to talk about in a second: the erythema multiforme, the Stevens-Johnson syndromes, and the toxic epidermal necrolysis. These are the most severe things that we're going to see, and these are the ones where you really do need to engage the assistance of an emergency medicine specialist to stand any chance of dealing with these. So when we're looking at these drug eruptions, I think you can, depending on the severity of it, it may be that in the short term you want to just withdraw therapy and get the owners to monitor them. But when they're much more severe, these are cases, unfortunately, that you need to see. There's a strong argument to suggest where you've got a potential drug eruption that you should give supportive care and do little else. And certainly that would be my first port of call, because you can't always be sure what the drug is that they've reacted to. Some of these dogs will react to drugs where you know what they've reacted to. Some of them, they've had 4 or 5 different drugs and there's different cross reactions with them. So you're better off taking them off all systemic treatments and just looking at topical therapy. And many of these dogs will settle down. If they don't settle, some people would suggest using steroids. It's a bit controversial whether they're beneficial or not, but if you're going to use steroids, you need to go in at significant dose rates. And if you've got very severe disease and owners with very deep pockets, you may consider using human intravenous immunoglobulin. And I've given you a recipe there if that's something you really feel you need to go for. But that really is desperation stakes where you really feel you want to go along that line. Finally, let's look at these 3 diseases. These are all pretty rare, but you are going to come across these from time to time. So erythema multiforme, Stevens-Johnson syndrome, and toxic epidermal necrolysis. And these represent a progression of a disease. So essentially, erythema multiforme is, I would suggest, the earliest stage of this presentation, and they progress through Stevens-Johnson's through to toxic epidermal necrolysis, and the prognosis gets worse as we move down that list. Differentiating between them is really, really difficult, and it's almost impossible to differentiate between these on the basis of the lesions that you can actually see. They're usually differentiated on the distribution of the clinical signs and on histopathology. But for most of these, you do not have the benefit of histopathology, because by the time you've taken a sample, the time you've sent it off, the time you've got a result back, even if it's ultra quick, the dog's usually dead unless you've actually done something a little bit more dramatic than that. So this is the table I would refer you to. It's really quite an old paper now, but as far as I'm aware, it's not been updated, because what was true then is probably still pretty true now. And this goes through the different stages of the disease. So erythema multiforme minor, erythema multiforme major, Stevens-Johnson syndrome. Then there's this overlap syndrome that you see between Stevens-Johnson's and TEN. And what you look at when you're looking at these lesions is you look at the type of lesion that's present. You look at the number of mucosae that are involved. You look at the amount of erythema, the amount of macular, papular eruptions as a percentage of body surface. And then the really important one, because this is what determines the prognosis, is the amount of epidermal detachment that's there. And obviously, the more severe the epidermal detachment, the worse the prognosis is going to be. And many of these dogs, particularly where you're looking at TEN, can have vast areas of their body where we've got the epidermis detached from the dermis, and you just gently push the epidermis and the whole thing will just slough off underneath your fingers. These are almost like dogs with very severe burns. So let's a little bit more information on each of those. Erythema multiforme, first of all, acute onset, these macular papular lesions. Many of these are the classical target lesions that we see, but some of them can be a little bit more serpiginous, so snake-like in their appearance. Usually you're going to see this affecting the ventral abdomen, so particularly the groin and the axilla. But you will see erythema multiforme affecting the ear pinny, and it can just affect the ear pinny, almost like a fixed type of drug eruption. These animals are usually pretty sick, they're depressed, and they're anorexic. This we know is a T-cell reaction, and unlike Stevens-Johnson's and TEM, this causes patchy keratinocyte death rather than confluent keratinocyte death, as we see with those other 2 diseases. We know erythema multiforme in man is triggered by viral infection. There has been papers in the literature suggesting the same may be true in the cat, but in the dog there are multiple triggers. So drug can certainly do it, but we've seen erythema multiforme in response to different foods. Certainly I see it in dogs with internal neoplasia, particularly pancreatic, liver tumours, connective tissue problems, and of course many of these are completely idiopathic. What does it look like? A couple of examples here. You can see on the left-hand side these typical target-type lesions where you get the central area of pallor and then the erythema around the outside. And then the one on the right-hand side, a dog with much more sort of diffuse-type lesions that tend to be a little bit more linear, perhaps bordering on serpiginous. A close-up of the lesions here, you can see they're slightly elevated, erythematous, ulcerated, and then again on the right hand side, lesions on the ear pinna of a dog, purely caused through erythema multiforme. In this particular case was a dog with a fixed erythema multiforme reaction on its ear because it had a pancreatic tumour. So an external cutaneous manifestation of an internal disease. This is one that I pulled out the literature, which I think is an indication as to sometimes doing very little is the thing to do. So this is a case of erythema multiforme associated with sulfonamide-based anticonvulsant. And what you can see is the presenting signs on the left-hand side, confirmed on histopathology as erythema multiforme. And this dog was just given supportive treatment. The drugs were obviously withdrawn because they were suspicious of a drug eruption. And after 72 hours of just supportive therapy, bathing, nutrition, analgesics, they found that this dog produced a really dramatic improvement. So sometimes less is more in these cases. So would I advise on these over the phone? Almost certainly not. When we're looking to EM and Stevens-Johnson's and TEN, these are cases that need to be seen. They need supportive treatment, they need fluids, they need nutritional support, they need analgesics, they need antibiotics, bearing in mind, of course, that if this is induced by drug, we need to be really careful that we don't select drugs that are related in any way. Some people will suggest immunosuppressive therapy. Certainly, in my experience of erythema multiforme, I will give them time to settle down. And if they're not settling by themselves, I will usually add in another drug. And azathioprine I found useful, cyclosporin I found useful. And more recently, there are reports in the literature of oclacitinib, so Apoquel, being used to treat erythema multiforme in dogs. So the two really bad ones now as we finish, Stevens-Johnson syndrome, toxic epidermal necrolysis. This is a per-acute disease. These are very, very sick dogs indeed. They have severe systemic signs, widespread disease, painful skin, often starts on the trunk. They almost always, if you think back to that table, have dramatic and quite generalized mucosal involvement, and almost always they have involvement of their foot pads. This disease progresses very quickly. It starts with these erythematous macules and patches, as we see with erythema multiforme, but very quickly we get this widespread necrosis of the epidermis, this much more confluent reaction that we see, and we see epidermal detachment. That's the hallmark with this widespread ulceration with gentle pressure on the skin. The main triggers for Stevens-Johnson's and toxic epidermal necrolysis are drugs. So antibiotics, of course, potentiated sulfonamides, when they were used more, we saw this disease more frequently, but also cephalosporins and penicillins, and things like anthelmintics are also very commonly implicated. I've also seen it with non-steroidal anti-inflammatories. A few pictures to finish, some very dramatic pictures here. Really severe ulceration in the mouth of these dogs. Obviously our differentials will be things like these chronic ulcerative diseases, autoimmune disease, things like epitheliotropic lymphoma can do this, but they're not as acute onset. This is a per-acute disease that is not there one day and can basically happen in the blink of an eye. Another one here for you. This is taken from a really nice article from 2014 from Veterinary Pathology, again, which characterizes both the clinical and microscopic characteristics. And what I've done for you here is I've given you a picture from the article, which is on the left-hand side with the number 5 on it. And I've compared that with a dog with pemphigus foliaceus. The dog on the left-hand side developed those signs probably within 24 hours. The dog on the right-hand side developed those signs probably within about 24 days. So for me, although they're similar in their clinical presentation, the acute of onset and the potential for the rapid progression makes that one on the left the emergency. And also that's ulcerated. You've got full thickness skin loss on there, whereas the one on the right-hand side may look dramatic, but that's much more erosive and much more crusting. Similarly here, again, another picture from that article on the left-hand side. That's full thickness skin loss that you can see in the dog on the left-hand side, acute onset with the loss of the skin, and I'm comparing that to the one on the right hand side. That is a dog with generalized erythroderma, which has got epitheliotrophic lymphoma. The one on the left hand side took 24 hours to develop. The one on the right hand side probably 24 days. So insidious, creeping onset compared to the one on the left hand side, which makes that a case that we need to see. Finally, another paper for those of you who are interested, any dermatologists in our audience here from veterinary dermatology. This is a really nice paper, a really nice review paper, again, looking at erythema multiforme, Stephen Johnson's and toxic epidermal necrolysis. And these very dramatic pictures are taken from that article. And this is how you can, how perhaps I can best explain the very, very severe prognosis and how rapidly these animals will deteriorate. These dogs will develop signs like this literally in 24 hours, which is why when you see these very acute onset cases, when there's a history of drug administration, which is why you need to see these dogs on an urgent basis, and why you need to seek the advice of someone who perhaps is more equipped at managing these. Certainly, I would advise on these, but I want to seek the expertise of a medic, because we're looking at advanced supportive therapy with these animals. They need analgesia, they need nutritional support, they need aggressive fluid therapy to compensate for both the massive electrolyte loss and of course the protein loss, because these animals are sloughing their skin. Many of these dogs have severe secondary infections, so in the same way we'll get colonization of a burn with Pseudomonas. They often have secondary Pseudomonas as well. So these are hugely challenging cases that need to be seen on a very urgent basis and need to be seen with specialist help and assistance if you possibly can. So last couple of slides are take-home messages from today. Therapy based on virtual consultations and examination is never, in my opinion, a substitute for a face-to-face consultation and a more extensive workup and treatment interventions. It never can be. It's only going to be a stopgap where it is appropriate. There are owners who perceive emergencies such as pruritic skin disease, and there's an awful lot that you can do to manage these over the phone without having to see the animals, and a lot of them will get better without being seen at all, which of course opens up the whole conversation about why you should charge for your professional advice when you give that advice over the phone. True emergencies are the cases where we get these very acute onset areas of swelling and very severe acute onset generalized ulcerative disease. They are rare. Erythema multiforme, Stephen Johnson's, toxic epidermal necrolysis are rare diseases indeed, but you need to be aware of them, and you need to be aware of how you need to manage these and the necessity to ask for special advice if you can actually get hold of someone on a virtual platform. So that was my last slide. I think we're just coming up to time. Just like to say thank you. This is my two Labradors, my dirty allergic Labrador Safi, who's the yellow one, and my beautiful chocolate Labrador, who is the best behaved dog in the world, which compensates for having the naughtiest yellow dog in the world. This is us walking last week out in the lakes. So I'm happy to take photos. I'm happy to take questions even if anybody has got any.
Thanks so much for that, Sue. It was yeah, just really good stuff there. Very pragmatic and practical. Even I could understand it, and that's saying something. As someone that shares their bed with a occasionally itchy dog, I can definitely say I would be one of those annoying owners self-reporting a 10 on the PVAS scale. So that point was well taken for sure. We do have some questions in here. We've had questions flooding in. The first one I want to put to you is from Martin. And Martin says, if clients do not have over-the-counter medications, such as human products, should we really be sending them to pharmacists who can only sell those products under direction of a veterinary prescription? Plenty of clients buy those products and use them on animals without understanding the medico-legal position. Is a pragmatic approach better than a bureaucratic approach? And there's even a smiley face in there for you, Sue.
So the question is whether we should be sending clients to buy over-the-counter medication or not. Was that?
Yeah, I think that's the crux of it. Yeah,
summarising it. I think with all of these things, it's a compromise, isn't it? I mean, we've all had conversations with clients where clients have phoned us up and they have got a dog that they feel has got an emergency, but they've just got back from the pub and they've had too much to drink and they don't want to pay for a taxi, or the car's broken, or they haven't got a car and they can't get their animal into the vet, but they've got a Tesco's Extra around the corner. And I think you have to use your clinical judgment as to what's going to be in the best interest of the animal. And so whilst I am not an advocate of remote prescribing of POMV drugs, I do not think that's appropriate. And even though I'm a telemedicine provider, that is not something that I did during lockdown. I do think it's appropriate to send someone down to the chemist to go and get some Piriton, because it's an incredibly safe drug and it's only going to produce benefits.
Yeah, that makes perfect sense to me. That decision, sort of pragmatic decision based on animal welfare, makes sense to me. And with you on the sort of remote prescribing of POMVs, except where you have that ongoing, you've seen the client recently, seen the patient recently physically. We've had quite a few questions in from Joao. One of them here is whether you see cutaneous lymphoma as an urgent case also.
No, I don't. I mean, yes and no. Generally speaking, no, because again, epitheliotropic lymphoma is an insidious disease. This isn't something that comes on overnight. The problem that you have is that some of these animals will get acute crises, in which case it may be that it needs to be seen on a more urgent basis. But generally speaking, autoimmune skin disease and neoplasia, I would not consider to be cases that need to be seen on an urgent basis, because that it's very unlikely that animal is going to die if it's not seen then. Whereas a dog with one of those severe immune-mediated drug type reactions will die if you don't see it. It will probably die even if you do see it, but at least you've seen it.
For sure. And I think it's important to be clear here, just because we're saying it's not an emergency doesn't mean you shouldn't see it at some point. But we were talking before we went on air, Sue, and you're saying the things you've heard, and I've heard much the same, about practices facing unprecedented pent-up demand and reduced capacity. And we can't see everything at the minute it presents to us. So giving people the tools and the know-how to triage and decide what absolutely needs to interrupt everything else and be seen now versus what can be scheduled in at a time when we do have the capacity to see it, that's really what we're driving for, right?
Absolutely spot on. I mean, in a perfect world, we'd see every single case. We'd make an appointment for every single client that phones us up. But there's only so many hours in the day and we've only got so many members of staff. So this is all about prioritizing, but also giving veterinary advice to help support animal welfare. And there's lots we can do to help with that. But I firmly believe we should charge for it. I mean, I'm a great advocate of charging for our services rather than charging for products. And I don't feel that if a client phones you up and you give them advice over the phone and it sorts that dog out, I don't feel it's unreasonable for you to charge for that. We're really very bad at doing that as a profession. And I think the sooner that we change that mindset, the better it's going to be for all of us.
For sure. I think we're the victim of our own assumptions and biases there, because we see on the PetZap platform, we've processed over 3 million in payments, Veterinary Connect revenue through the platform. And the reviews that we get from pet owners are about how easy it is to pay. They're delighted that they were able to have their query answered in a way that didn't interfere with emergency cases, didn't clog up the phone lines. The pet owners are willing to pay for our professional expertise. We just need to be willing to ask them to. We need to be willing to request the payment.
And you're absolutely right, Tom. We get stuff through our platform, and some of it is really very simple stuff. It may just be a skin tag on a dog. Then an owner wants to be reassured that that's all it is. And they're really happy to pay for professional advice. They're really happy to pay, to have that reassurance that it's nothing that they need to worry about. But at the same time, I think you're devaluing your advice if you don't charge for it. I hear the clock go on when I phone my accountant. The clock starts ticking the minute I start to talk to them. So, I just think we need to charge for our professional work. We are busy professional people. We've trained. And when I'm saying professional people, I'm talking about nurses and vets. I'm not just talking about vets. I really strongly feel we should charge for our time.
Yeah, Yeah, makes perfect sense to me. In terms of the sort of pragmatic approach and trying to think of interventions that could improve the sort of welfare status of the animal in the time it takes for it to actually present to you physically, there are a few concerns here about sort of downstream consequences. So Laura asks, how long after using frontline spot on can you give, for example, Brevector? And I think this came with the sort of advice around fipronil being a maybe a second or third tier help in scabies.
Yeah, I mean, we're talking here about compromise with all of these cases. I am not sure whether you can't use the two at the same time. I would need to check the data sheet, and I would probably want to check with the manufacturers of the different products to be sure of that. But again, I'm talking compromise. Of course I want to see a dog that's got scabies. Of course I want to give it appropriate treatment. Of course I don't want to send them down to my local supermarket and get them to get fipronil. But I'm talking about when all else fails, what else can I do to try and give that dog some relief until I can get to see it? I would prescribe fipronil. So if I'm forced into that situation, and I would hope that wouldn't be very often, to be perfectly honest, because I would have thought most of the clients that are contacting you are your clients, and that they are animals that are on your books and that you probably check fairly regularly, and you should be able to get them to come down and pick up your isoxazoline of choice. I would hope that that shouldn't happen very often, but I would probably just check my data sheet before I would prescribe it to you. So I'm not going to say it's a week or it's 2 weeks. I'd want to check on that before I prescribe it.
For sure. Yeah, I do appreciate so you giving this kind of pragmatic advice that covers lots of different scenarios. But yeah, if you can get them in and give them the ideal treatment right away, then that sounds like what you very clearly said should be done. Zhao as well, sort of on a related note, said, would the antiparasitic drugs like fipronil or isoxazolines administered at home interfere with a diagnostic test later? If the animal stops itching and the visit is delayed, how would it impact the diagnostic workup? Like, are we going to make things? And again, yes, the animal welfare is key, but are we going to make things harder for ourselves? And how can we sort of de-risk that?
So I don't see that making a dog. So if a dog responds to an ectoparasiticide, then the dog has got an ectoparasite. Would be the way that I would address that. And to be perfectly honest with you, I don't have any problem. Why would I want to do any diagnosis? Because empirical therapy is a diagnostic tool. Empirical therapy with an anti-inflammatory isn't a diagnostic tool, but empirical therapy with an ectoparasiticide, I would suggest, is. And there are lots of cases we know where we have a dog that we're blinking sure has got scabies, and we do some skin scrapes from it, even though it's got lesions in all the predilection areas, and we don't find any scabies. And so guess what we do? We give it some empirical therapy and it gets better. So I don't have any problems if it gets better. I have concerns if it doesn't get better. And let's face it, there are lots of dogs that we treat that get better and we don't know what's wrong with them.
Yes.
I don't have any problem with that at all, as long as it gets better.
Yeah, that's a great point. That the sort of the treatment that you've given can in itself be a diagnostic indicator. I like that, and it can give you a guidance on what tests we should be running next. So we have come to time. Just more comments than anything here. Martin says, "Good to hear that hands-on is the best option. We will carry on with that approach." I think Martin's got a point, right? We said from the beginning that virtual care cannot replace physical examination, physical interactions, but it's about creating these seamless, joined up online to offline interactions. The telephone call is not a hands-on interaction either, and we don't banish telephones from our practices. So it's about being pragmatic in the tools that we use to try and maximize the impact we can have on the lives of our patients and their owners without requiring any more of us. The veterinary team, the veterinary professionals, preferably requiring a little bit less of us and allowing us to not have our working day dictated to us by who happens to get through on the phone line first. And I think there's one thing that we haven't touched on in this talk, Sue, which I'd be interested to get your take on. As very much not a specialist dermatologist, skin cases were some of the most frustrating cases that I had to deal with in practice. and also some of the most rewarding, I should say. And there were cases that I would have liked to have seen every 3 days to check response to treatment, to really get to the bottom of the case as quickly as possible. But I didn't think the owner would be willing to do that. Maybe every week, maybe every couple of weeks, they'd come in and see me if I was lucky. And now you've got the added sort of pressures, even more than before, of and not having the capacity to see them as often as you might like. It strikes me that a virtual check-in, having someone send through a photo on a chat or a video on a chat of how things are going, and whether you want to see them sooner or whether you want to adjust the treatment, that sort of makes sense to me.
I completely agree, and I would absolutely endorse everything that people have said about virtual consultations. Do not ever replace face-to-face consultations until technology advances and we can palpate an abdomen and listen to a dog's chest and look down their ears. There is nothing to replace a face-to-face consultation. But I do think this hybrid type of approach, where we're using our virtual platforms to complement the way in which we work and to enhance the service that we give, and also using the whole of the vet-led team. So using our veterinary nurses, we're not asking nurses to diagnose, we're asking nurses to do follow-ups. There's no reason why, you can't have a nurse based at home, gets around all sorts of problems for a nurse, who's doing follow-ups, who's doing follow-up checks, talking to clients with their dogs with their diarrhea, checking they're settling down, checking to see that the lesions on the dorsum of the dog have improved. I think it's a really useful way to enhance the service that we give, and we're all about improving animal health and welfare. I think it's a great way to do it, but it's part of a holistic approach. It's not the only way that we should be dealing with these cases. I very firmly believe that.
For sure. It still puts the sort of local veterinary team at the heart of the patient advocacy process. And we've got another comment here saying, thanks for a fantastic presentation. They loved it. So that's some great feedback there for you, Sue. Someone agrees with me for sure. I want to be respectful of your time. I know you've had a long day of lectures, delivering lectures. But I, for one, am off to listen to more from you on the Skinflint podcast. If people do want to hear more from you, perhaps they want your help with some of the more complicated cases that they come across, where should they go? Where can they reach out?
So we're available on the Virtual Vet Derms platform. Thank you very much for that plug, Tom. We provide 2 levels of service for vets. We have the situations where vets see a case and they have absolutely no idea what's going on. So we get them to fill in a history sheet, upload some photos for us, and then what we will do is talk them through the clinical signs, differential diagnoses, diagnostic tests and treatment plans. And a lot of vets find that really useful. And of course, that's CPD. And then we have a lesser service, which is, well, it's not lesser service, a different service, which is where vets know what's going on. They know they've got a dog with lupus, they know they've got a dog with Pseudomonas otitis externa, and they just want a treatment plan. And so those are cases where they just fill out a brief history again and say, I've got this dog with Pseudomonas otitis, this is its sensitivity pattern, what in heaven's name can I use to treat it? And then we will put that through. And you said at the beginning very kindly that I very firmly want to make specialist advice available to everybody. There are very few specialists in the UK in dermatology. It's the same with ophthalmology and neurology. They're very, very low on the ground. And so this is a way for vets in practice to manage their cases and seek specialist advice without having to actually send their clients off to a specialist, because we know that clients often don't want to go to a strange place. Their dog doesn't travel well, they don't travel well, they're not very happy. COVID has made that worse. So our service is there to help vets manage cases better. It's not to replace what they do, it's to help them improve animal health and welfare.
Sounds great. And I hope you can see these comments coming through. So we've got whoop whoop, thank you, really useful, thank you from Mandy. Janine says, very good presentation, thank you for sharing your experiences. And you've got another thank you here, great presentation from Joao. Thank you, Sue. Thank you all for tuning in. I hope you will check out PetsApp. You can go across to petsap.com for more webinars. As Sue mentioned, ophthalmology there. Our last webinar with the London Vet Show team was with Gareth Jones on ophthalmology, so you can check that out. And if you are, facing phones ringing off the hook, high numbers of missed calls, pent up demand, reduced capacity, and you are looking for tools to help you better manage that, put you back in charge of your workflows and not become subject to the tyranny of the telephone, as we call it, then we'd love to give you a demo of what we've built at PetsApp, where we have been able to reduce missed calls by 85% and really sort of improve the lives of veterinary team members, while also improving the lives of pet owners and pets, which is what we're all here for, I guess. Thank you, everyone, and thanks again to Sue.
Thank you, everyone. Take care. Good night.